I'm Ivy Guardiola from AdventHealth, DeLand, and Fish Memorial. Before we start this conversation, since we are maintaining social distancing, 6 feet, we're going to remove our masks so we have a better conversation.
Aesthetically, it may be better if I left my mask on.
So today with us, we have Dr. Thomas Corbians. It's a pleasure to be with you today, Doctor, because you have been with us since 1986 here at DeLand. You're the director at AdventHealth DeLand Vascular Laboratory, and also it's an honor that you're an assistant clinical professor of surgery at Florida State University, and you're board certified in general surgery. So welcome, Doctor.
Well, thank you for asking me to talk about inguinal hernias.
Excellent. So let's start. Doctor, tell me a little bit, because I've heard about hernias in many body parts, but what are the most common hernias that you see in your patients?
Well, in the United States, probably the most common operation done is an inguinal hernia repair, and that's a hernia that occurs down in the groin. Happens mostly in men. There's about 9 times more men who have hernias than women, but it does happen in women. Over the course of their life, 27% of men might see a hernia, and maybe 3% of women may see a hernia. It's not unusual for women to have hernia, but much more prevalent in men.
Okay, that's good. Good to know. What causes the hernias? And is there any way that we can prevent them?
Well, not really. It has to do with predominantly male anatomy. When we are being born and when we're having our body parts are being made, in men, the testicles move from around the kidneys and go out into the scrotum.
Okay.
So there's a weak area there where the blood supply goes through the abdominal wall to make sure that the testicles are outside the body where they work the best, and at the same time, that weak spot leads to the occurrence of hernias. And so we see these occur in newborns. What many people have a child and say, oh, they've got some small hernias where that hole has not closed appropriately. But more commonly, we see these in older men, probably from their teens out to their 60s or so. And so they can happen on one side, both sides. We also see them in women. They can be in the inguinal canal of women as well, or it can actually be femoral hernias as well, which are near the blood vessels on the top of the leg.
Oh, interesting. So nothing in particular that we can do to prevent them?
It's Providence.
It's Providence.
Just
okay. So if the hernias start, bothering us, what should we do about them? Like ignore them, go to the ER, come and see you? What should we do?
Well, it turns out that if you look at your hernias, let's say if you're a gentleman and you have minimally symptomatic hernia, or hernia that you notice a bulge when you're in the shower, and you could push it back in easily and it's not causing any problems, you can make a case to not do anything about that hernia. You can just watch it. All right? But if the hernia cannot be pushed back inside, or if it's causing lots of symptoms, we would recommend that you have surgery for that type of hernia. Also, if you have a minimally symptomatic or a asymptomatic hernia that you just want fixed because maybe it bothers you a little bit when you're moving things around the yard, again, that hernia can be easily fixed. You could choose surgery, or you could choose another old-time remedy, which was a truss. Trusses have never been shown to be particularly effective. They can actually scar that area, make things more difficult. We don't really support the use of trusses. But there are certain subsets of patients who are too sick to have surgery, where maybe a truss could be the best answer for those patients.
Oh, good to know that there are alternatives, and it's good to go to a professional that actually knows what other recommendations for us to follow.
And who doesn't?
Yes, and who doesn't? Yes. So tell us, because I've heard a lot about hernia repairs, something about mesh, some other treatments, procedures. What are the pros and cons about different procedures? Minimally invasive, I've heard a lot about it. Can you tell us a little bit more about it?
Probably the biggest question I get in my office is about mesh. And everybody's heard the attorneys online talking about mesh. Until about 1986 or so, we fixed hernias without mesh. There were a number of techniques that can be used to fix them without mesh and get really good results. But meshes transformed hernia repairs till now they are the standard of care when we fix hernias. There can be problems with mesh, as there can be problems with anything, but the simple truth of the matter is mesh hernia repairs are the gold standard for repair. Now let's say somebody says, I don't want to have a mesh repair. you can do a non-mesh repair, but they'll be more apt to have a recurrence from a non-mesh repair. So you have to weigh this at the time. If someone's fear of the mesh outweighs their fear of a recurrence, you may want to just do a non-mesh repair, and we do those. That's something that we can provide. But for me, I've had 2 hernia repairs. Both of them are with mesh, no problems. And I can say that generally speaking in practice, when we use meshes, it's not a problem. There are a couple of different ways you can fix these hernias. You can do an open repair, or you can do a laparoscopic repair. The laparoscopic repair could arguably be said to be, oh, it's a sexy repair. You go in laparoscopically and with 3 little bandages and you come out. Like everything else that we deal with in surgery or in medicine generally, there are pros and cons to both repairs. The open repair can be done under a local anesthetic. The piece of mesh that we use is much smaller, maybe that big, as opposed to the laparoscopic repair. The laparoscopic repair can be considered to be less painful, but also has a higher recurrence rate. And the piece of mesh is about that big. So when you look at the pluses and minuses, again, 2 people given the same information can come up to 2 different conclusions about how they want to proceed. And so in this case, we speak to them about it and say, what would you like to have us do? Would you like us to do an open repair? Would you like to have a laparoscopic repair? And people choose accordingly.
Oh, that's good to know. That's excellent to know, Doctor. Any other type of recommendation that you would like our audience to know about hernias, about that discomfort? Anything else that you want to add?
I think the major thing is that when you think that 60,000 Americans will die every year from complications of having a hernia. Oh. So many a time we've been called in the middle of the night for somebody who's got an incarcerated hernia and their intestines are trapped outside their body. Oh, wow. The risk of this happening is very low, but if it happens, it can be a catastrophe. And so what we want people to be aware of is if they have a symptomatic hernia that really is bothering them, or one that they're having trouble getting back inside when they lie down on the bed and try to push that back inside, that's a hernia that needs attention. And we would much prefer to see those patients before they become an emergency case, where at that point, very big surgeries may be necessary to repair what is wrong. So I'd be on the lookout for that, but recognize that for many hernias, they can be an elective case, done when it is convenient for the patient. Safe, reliable, wonderful surgery that prevents a lot of illness in a lot of people.
That's excellent to know, Doctor. Thank you so much for your time and the information. It has been wonderful.
I'm happy to do it.
Thank you.